Uh, Good evening, dear friends. So today's topic for our Young India Intensivist Sunday webinars is tropical infections, and we'll be talking about malaria, leptospirosis, and scrub typhus. So it's been organized by Dr. GOGIA, sir. Sir is senior consultant in internal medicine and infectious diseases at GANGA RAM Hospital, New Delhi. And I hand it over to him to introduce the speaker and the topic, and then we will start.
Thank you, Dr. Tapesh. It's always a pleasure to have to be with you on these webinars, which are a great initiative for all the students in critical care and other faculty. So today we have a very young, budding ID physician who recently joined us, and she's full of energy, and she put in a lot of hard work and get the slides up today. Dr. ANIVITA Agarwal, who is DM infectious disease from All India Institute of Medical Sciences, New Delhi. And she would be discussing one long case, which is going to give you a flavor of a couple of tropical infections, and probably she's going to discuss the tropical infections which are in the topic today. So I would hand over to Dr. ANIVITA to take us through the journey of an interesting, challenging case which we happen to manage in the last few months, and she will be discussing, and obviously we are there, and Dr. Tapesh will be taking the discussion ahead. Over to you, Dr. ANIVITA.
Thank you so much, sir. Thank you, Dr. Tapesh, for this wonderful opportunity. Hope I am able to do justice to the time and to the topic, because it's a vast topic and there's so much to present. There is so much to learn. So I shall be taking through a case. Let me just share my screen. Is my screen visible?
Yes, please start.
Yeah. So I shall be discussing a few tropical infections that are commonly seen. It's very important for us to keep in mind the epidemiology, the clinical features, and the various plethora of their symptoms that they present with. So here we start with a case, Mr. AB. He's a young male. He's a goldsmith and he resides in Delhi. He has no other prior known illnesses. He presented to the emergency in September, and he had history of fever since 7 days, which was insidious in the onset. It was documented up till 102, and it was continuous fever with chills and rigors. Now, this patient also ended up having shortness of breath since 1 day. He said that he was short of breath on exertion. It was associated with dry cough. It was MMRC grade 2. There was no features of hemoptysis, pedal edema, chest pain, or palpitations. On further asking history of, he did not have any joint pains or rashes. He did not have any urinary symptoms, any further abdominal symptoms. He did not have decreased urine output. There was no altered behavior or headache. He did not travel to any other place in the recent past. There are no history of pet at home. He did not have any close animal contact, and no other family member was having any similar complaints. Now, in the emergency and examination, he was alert. He was febrile with 101 degree Fahrenheit of fever. His vitals was essentially, he was tachypneic with a respiratory rate of 42, and he was just maintaining saturation on an NIV with an FiO2 of 50%. His PEEP at this time was 6 and PS was 16. He also had pallor, although there was no pedal edema or icterus or any rash noted. On thorough examination, he had bilateral coarse crepitations, which were infrascapular, interscapular, infraaxillary, essentially basal crepitations. And on deep palpation, he had mild right hypochondrium tenderness. Rest of the system examination was essentially within normal limits. Now, he had got some labs done from an outside hospital just prior to the presentation at the emergency, which was 1 day before, where his hemoglobin was 7, his TLC was also reduced, and he had thrombocytopenia of platelet counts of 50,000. Whereas the next day at emergency, when we saw him, his labs further deteriorated. His HB worsened, and his thrombocytopenia also worsened. At this time, his creatinine was slightly elevated 1.3, his bilirubin was slightly elevated 1.6, although transaminitis was not there. ALP, sodium, potassium, and PTINR were within normal limits. We performed an ABG analysis in which we see that lactate was elevated and the patient had some component of metabolic acidosis. Now, to remember that he was on NIV with an FiO2 of 50%, his PaO2 is that of 273. This was the chest X-ray at presentation in the emergency. Now here I would like to pause and I would request Dr. Gogia to discuss on what all possible differential diagnosis would we want to keep in mind with such a presentation. So to remind, this patient is a resident of Delhi. The patient is presented in the monsoon season. He has come with acute febrile illness with shortness of breath for 1 day. And he has cytopenias, he has some amount of liver dysfunction, he has some amount of renal dysfunction, and his X-ray suggestive of respiratory distress, probably ARDS. So how should we go about it? What all differentials should we keep in mind, sir?
Yeah, Dr. ANIVITA. I think Dr. Tapesh, would you like to comment here before I say in something, because I've been part of management, so.
Well, sir, actually, a lot of differentials are possible here. I think considering the three diseases we are talking about, you cannot rule out malaria. You know, malaria is known to cause ARDS. There's nothing much else. You know, there's thrombocytopenia, and of course, TLC is slightly on the lower side. So, you know, malaria has a normal TLC generally, can be slightly decreased at times. Then coming to leptospirosis. Well, leptospirosis classically is so severe, you know, normally you have significant jaundice and renal failure. But there is a third form of, you know, there's a mild form of leptospirosis, there is a severe form of leptospirosis, and there is a pulmonary form of leptospirosis. So you cannot pulmonary form of leptospirosis, which is characterized by hemorrhage, pulmonary hemorrhage. And the third thing is about rickettsia. So, well, rickettsia, you know, normally patients would almost a lot of patients have either a HR or, you know, some kind of a rash. So rickettsia would be a little less likely, but sometimes they don't have a rash. All of them don't have a rash. All of them don't have an HR. 50% only have an HR. ANIVITA has not pointed out about the HR. She did say about the rash. So HR has to be looked for actually, because it's hidden sometimes. And we have had patients who are presented with ARDS. Scrub typhus has come frequently with just ARDS. So those are the things I would like to consider, you know, since we're talking about these three diseases, that is what comes to mind as of now.
Yeah, so you rightly discussed all this. So, could this be some, this patient has pancytopenia, so the hemoglobin is low, the TLC is low, the platelets are low. So, uh, could it be some kind of a viral illness also, which could be there, which is causing thrombocytopenia, TLC? That also comes to my mind. And, there is mild transaminitis. Actually, transaminitis is not there, but mild hyperbilirubinemia and AKI. So, some kind of a viral illness also probably, and obviously malaria and scrub can always be there, and rightly said, but you may see HR in around 50% of patients with scrub, but generally it is you have to look for, as you rightly said, in the axilla or in the lower back or sometimes in the groin area. So you have to uncover and examine. Okay, Dr. ANIVITA, tell us how things unfold now and what do you think?
Thank you so much for your insights, sir. So as we shall be going through all the diseases and all the differentials one by one. So what came, I'm sorry, yeah. So what differentials we kept in mind was, to begin with, as sir said, malaria, scrub typhus, dengue, and leptospira are the ones which come to our mind when we see a patient with hepatorenal dysfunction, with ARDS, and with acute febrile illness. Other than that, severe form of enteric fever, severe form of influenza have also may present with similar features, where the patient might require aggressive ventilation within 7 days of illness at presentation. Although Delhi is not a region for melioidosis, this might also, in the southern parts of the country, this might be a similar picture, how a patient with melioidosis might present. A very lower down possibility that we kept in mind was severe form of sepsis with MODS, initiated by any other viral illnesses other than influenza or bacteremia that was yet to be evaluated. So with these differentials in mind, we started the patient empirically on artesunate. We gave the patient ceftriaxone, doxycycline, along with other supportive management. Now let us discuss the initial common differentials one by one and then take on further with the case. So to revise our classical undergraduate teaching, malaria is a vector-borne disease which can cause severe multi-organ dysfunction to mild illness. The agent is, there are 5 agents currently that are running in the country: falciparum, Plasmodium vivax, Plasmodium ovale, malaria, and Nolency. The vector is essentially female Anopheles mosquito, and humans are the accidental hosts. Here, we can see the life cycle where after the bite of mosquito, we have an exoerythrocytic stage where sporozoites are formed, which go into the RBCs, and they, in cyclical form, they form early, late, and mature trophozoites. This cycling in erythrocytic stage is what is responsible for the cyclical patterns of fever, and after which the cycle is terminated in the form of gametocyte production, and further the bite of mosquito transmits the disease to other humans. In the current fact sheet of WHO in 2021, it was estimated that almost more than 6 lakh deaths were there because of malaria. And most of these were cases from African region. In WHO Southeast Asian region, the main contributor for malaria is India, which has over 58% of Southeast Asian region prevalence. And amongst these, Orissa is the state which has the highest incidence of malaria. More than 22% of our population in our country lives in high transmission areas, and there are almost 50 cases found to have falciparum, 50% with vivax, and almost 13% cases with mixed infections. There have been case reports from Chhattisgarh where all 4 species of malaria have been found in a single patient. So the clinical features are classical malaria paroxysm, which has fever with chills, and the fever can go up to high grade with profuse sweating. And as we all are aware that the fever pattern varies from species to species. So the other symptoms are severe headache, fatigue, and profuse night sweats, which are seen in almost 90 to 100% of the patients. Along with that, arthralgias and abdominal pains might also be seen. Rash is not a cardinal feature of severe malaria. And further, severe signs of organ dysfunction may also be seen in severe malaria. So the diagnosis is multifold. After we have a patient with clinical suspicion, the first thing to get done is routine investigation, as was done in our patient, followed by direct microscopy and rapid detection of antigen testing. NAT and other PCR-based methods are essentially for testing of resistance as well as for epidemiological studies, which are not performed usually. So according to our, direct microscopy is the gold standard diagnosis. Here, the limit of detection is 100 parasites per microliter. Hence, with trained eyes, there can be speciation of Plasmodium, there can be diagnosis of mixed infections, and most importantly, we can determine the level of parasitemia, which is very important to monitor the treatment response. If the level of parasitemia does not fall by 75% within 42 hours, then we may suspect resistance. Now, there are various rapid diagnostic kits that are available in the market. Many of them have been standardized by WHO. Based on the HRP2 and LDH, we can determine that whether this is a Plasmodium species, which Plasmodium species are we dealing with. So the lower limit of detection can range from almost 2 to up to 200 parasites per microliter. Now, this specific kit that we're talking about has a sensitivity to detect more than 50 parasites per microliter up to almost 100% for falciparum species. And for non-falciparum, the sensitivity is up to 98%. So if we see how to determine a rapid diagnostic kit, this is a very simple kit which can be performed bedside of the patient, whether in the ICU or in the emergency. In the first case, we see that there is only one control line. This essentially means that the test is negative. And in case of high suspicion, we are supposed to repeat it within 24 hours. In the second kit, we can see that there are 3 lines that are made. One is for pan antigen, one is for Plasmodium falciparum antigen. Now, this could mean that there is falciparum alone, or it's a mixed species. Hence, a direct microscopic examination must be done at this level. The third example determines one line of control and the other line of pan antigen. This essentially means that the patient is infected with any of the species of Plasmodium other than falciparum. So this may be vivax, ovale, or malaria. It is important for us to understand that the HRP2 based kits, they remain positive up to 28 days of prior treatment. So hence a history of prior treatment by an anti-malarial drug is very important once we're interpreting such kits. PAN LDH marker, which can be there for PAN or for vivax. This is used to monitor parasite clearance. It can come out to be negative within 10 days of effective treatment. So what are the signs of severe malaria? As per WHO classification, if a GCS is low of less than 11, if the patient has severe prostration, there are episodes of convulsions. If the patient has metabolic acidosis with high base deficit and high levels of lactate, if there is ARDS, that is oxygen saturation is less than 92 with a respiratory rate of more than 30 and crepitations with an radiological confirmation. If there is hypoglycemia, if the patient is having shock, bleeding, DIC, severe anemia is one of the criteria of severe malaria, in which hemoglobin less than 7 is, or a hematocrit less than 20% with a parasite count of 10,000 is classically pointing towards severe malaria. Also, renal impairment with a creatinine more than 3 and a bilirubin more than 3 is indicative of severe malaria. So what is the reason why severe malaria is caused? It is essentially because of the properties of the antigen, which malarial antigen and which causes cytoadherence, rosetting, and clumping. This leads to severe interaction with the endothelial cells. It leads to infection of the uninfected RBCs, and it leads to further breakdown of RBCs and leading to hypoxia, parenchymal axonal damage. So this leads to severe complications such as we have a long list of complications of malaria that we all know of, like cerebral malaria and black water fever, DIC, etc. So how do we treat? So there are 4 core principles of treatment of malaria. First is early diagnosis and effective prompt treatment. Second is rational use of anti-malarial drugs in the form of combinations where required and in the form of region-specific agents. Third is combination therapy. A single agent versus monotherapy, a combination is always preferred, and based dosing to prevent the side effects. So for uncomplicated malaria, as we all know, if the patient is having vivax, then chloroquine may be given in chloroquine sensitive areas, followed by a 14-day course of primaquine. When we are giving a 14-day course of primaquine, we must ensure that G6PD deficiency testing has been done. However, when we are giving a single dose of primaquine, such as in case of falciparum, G6PD testing might not be required. So for patients who are tested positive for falciparum malaria in northeastern states where resistance is present with ACT and SP combinations, is artesunate combination therapy with artemether and lumefantrine is what is preferred, followed by a single primaquine. In mixed infections, we treat it as that similar of falciparum, but we give 14-day full course of primaquine. Now, if we are dealing with a severe or a complicated malaria and the patient is not able to take orally, we should start artesunate injection given at 0, 12, and 24 hours, followed by OD therapy till the time is able to take orally. Followed by, and the oral therapy is supposed to be given in full course, that is full 3-day course is to be completed. Now we move on to our next illness, that is scrub typhus. So scrub typhus is essentially a zoonotic rickettsial illness. It is caused by Orencia susugamushi, and with the same name, there is a susugamushi triangle defined on the map, which determines the area of maximum prevalence of scrub typhus infections found. The vector as well as the reservoir is the larva of trombiculate mite, which are known as shiggers. Now, there is transovarial transmission between the shiggers, hence this continues the life cycle. And this infects human accidentally via bite when coming close to such rodents or even the flora fauna, which is infected by these shiggers. So there's a study that was done, a systematic review, which was published in PLOS, which looked up at the seroprevalence in India. So the overall seroprevalence was almost 32%, and so much so that there is underdiagnosis of scrub typhus due to lack of laboratories which are testing for it. Multi-organ dysfunction have been reported in up to almost 17% of patients, and 20% of these required ICU admission. There was very high case fatality rate in patients who had myocarditis, who had shock, who had multi-organ dysfunction, and acute kidney injury. 26% mortality was seen in patients who had ARDS. So clinical features of mild scrub typhus fever start with fever, chills, and myalgias. There is excessive myalgias, body aches, and nausea, vomiting. The site at which the mite has bitten, there is a progressive necrosis which evolves into an HR. This HR might be seen in up to 55% of the patients. However, the presence of an HR is very, very specific. There might be some regional lymphadenopathy in the area. Subsequently, there is going to be vascular injury to several organs, which can lead to various catastrophic events such as DIC, platelet consumption, vascular leak, pulmonary edema, and even shock. Another review which was done from All India Institute of Medical Sciences. Here, scrub typhus patients were evaluated in the last 20 years, and over 200 patients of scrub typhus were compared with non-scrub typhus illnesses of acute febrile illness. Here we can see that there is a significant increase in chest infiltrates in patients with scrub typhus and ARDS. Also, myocarditis and altered sensorium has also been significantly found to be higher in such patients. Hence, these are some telltale signs which we can keep our minds open to when we are dealing with an acute febrile illness. In patients who were admitted to the ICU, respiratory complications in the form of ARDS and pulmonary edema was seen in almost 96% of the patients. The mortality here as well was found to be 22%. So thrombocytopenia was there in almost 86% of the patients, and less than 50,000 counts of thrombocytopenia was there in barely 50% of the patients. The duration of fever and the severity at the time of presentation was associated with high mortality. Now, how can we diagnose scrub typhus? So there's a classical Weil-Felix reaction, which is an heterophile antibody test. Although it has very poor sensitivity and specificity, it is very easily available across the country. The most specific and the most sensitive one is IFA, which is the gold standard of testing. However, it is very expensive. ELISA-based tests are highly sensitive, and if ELISA ELISA-based testing has been reported to be very similar sensitivity and specificity as of IFA, where the regional cutoffs have been targeted. So there's a study which is reported by Dr. Nitin Gupta and team, in which regional cutoffs are giving equal sensitivity and specificity as similar to that of IFA. Other methods are PCR-based testing, which have their own cost, although they're very specific. So the treatment of scrub typhus infection is doxycycline given for 7 days versus azithromycin. When these two drugs have been compared, there has been no difference in the outcome of the two groups in either the defervescence of fever or in the length of hospital stay. A recent NEGM trial, which was done from India by Dr. George Varghese, compared IV doxycycline versus azithromycin combination for patients with severe scrub typhus. Here, they found that the combination therapy was much superior to monotherapy in achieving the primary composite outcome of death at 28 days. There was it was superior in form of persistent complications at day 7, and it was superior to monotherapy in persistence of fever at day 5. There was also reduced incidence of persistent of complications at day 7. There was reduced complications in the form of respiratory, renal, hepatic, and central nervous system complications. So in our Indian scenario, if we are facing any difficulty in treating a severe case, we might try this combination therapy. Although there are many caveats to this study, hence the combination therapy must be judiciously used. Coming to leptospirosis, so there are various endemic states and high-risk states in India where leptospirosis is prevalent. Tamil Nadu being the most endemic state. Leptospirosis peaks in the rainy season in tropical areas and in late summer and early fall in temperate areas. It is associated with sporadic outbreaks or with outbreaks of flood and with a lot of waterlogging. So the reservoir and the carriers are rodents and even non-rodents. In what happens is that when there is waterlogging, all these rodents are forced to come out of their burrows and they contaminate the clogged water with their urine. Also, soil which is alkaline, salty water favors the survival of leptospiras over years. And the transmission can be with direct contact of this contaminated water or with close animal contact with infected rodents or non-rodent reservoir hosts. So as Dr. Tapesh was mentioning, so there is a mild form of disease and there's a severe form of disease. The mild form, also known as the anaectic form, has two phases, the acute phase and the immune phase. In the acute phase, that is within the first week of illness, there is fever, there's rash, and there is severe myalgia. So much so that the CPK levels are very, very high. There might be some conjunctival snuffling, there might be headache. In this stage, renal and pulmonary manifestations are very rare and very minimal. And thrombocytopenia and anemia are very less common. The next phase is the immune phase. This usually patients are asymptomatic and there is a self-resolving course of illness. Very few transfer to the immune phase. And here the patient ends up having a biphasic form of fever pattern, that is a renewed fever. And the patient again has headaches and myalgias. There might be presentation of aseptic meningitis and uveitis, which are classically very severe and life-threatening. Weil's disease is what is the severe form of leptospirosis. Here, it is classically presented with a hepatorenal dysfunction. There is jaundice, which happens within 4 to 7 days of illness, which is essentially conjugated hyperbilirubinemia. And the ALT, AST are usually within normal limit. The patient does not go into hepatic dysfunction, but the patient does not go into hepatic encephalopathy, but the patient has very high levels of bilirubin. Severe form of renal dysfunction in the form of acute tubular necrosis, oliguria, and even anuria can be present. There is severe hypoproteinemia. This worsens from the end of first week onward till the end of second week. So much so that the patient might require renal replacement therapy. If the patient is able to make it, then the patient improves by the end of fourth week. The pulmonary form of Weil's disease is the one which is most responsible for severe deaths. There is hemoptysis, there can be pulmonary hemorrhage, and devastating ARDS. The patient can go into severe DIC, anemia, thrombocytopenia, severe shock. The patient may have myocarditis and arrhythmias, aseptic meningitis. The rash usually evolves in the form of macular, and erythematous skin eruptions. Diagnosis can be made by clinical, epidemiological, and laboratory findings. The epidemiological history and the environmental exposure is of utmost importance when diagnosing leptospira in the non-endemic areas. So a suspected case is when we have clinical features meeting that of leptospirosis with a background of environmental exposure. A probable case is one which has IgM-based, either slide or latex agglutination-based or immunochromatographic-based test positive, or the microscopic agglutination test known as the MAT, having a single titer more than 100 in non-endemic areas and single titer more than 400 in the endemic areas. A confirmed case requires further robust evidence of leptospira in the form of either isolation of the organism with culture techniques or rise in the antibody titers via MAT. A seroconversion, PCR, and 2 rapid tests positive are also confirmatory. So the important to note here is the time of sample collection. CSF and blood can isolate the organism within first 10 days of illnesses, whereas urine is the only sample that can be sent to the laboratories for isolation after more than 10 days of illness. There's another criteria known as the modified FAINS criteria, which is adapted by WHO, which incorporates clinical, epidemiological, and laboratory findings to evaluate the possibility of leptospirosis. So here, a score of more than 26 gives a presumptive diagnosis of leptospira, whereas something between 20 to 25 gives a possible diagnosis of leptospirosis. Here we can see that a positive serology and a rising titer of microscopic agglutination test, the MAT testing, has the highest scores. Hence, once these are positive, with an epidemiological and a clinical background, we have a confirmatory diagnosis. So for treatment for mild leptospirosis, tablet doxycycline or amoxicillin should suffice. But to moderate to severe leptospirosis, recommended are penicillin, ceftriaxone, or ampicillin. However, there is controversy to whether antibiotics are truly required and truly efficacious in severe leptospirosis or not. So there was a Cochrane review in 2012 which reviewed the need for antibiotics in leptospira, where they found that the benefit still remains unclear in severe diseases. There is not enough evidence for or against the use of antibiotics. Antibiotics use might decrease the duration of illness by a few days, but this has not been found to be statistically significant. And selection of either of the antibiotics, penicillin, doxycycline, or cephalosporin, did not really impact the mortality or the duration of fever. Furthermore, there is no robust evidence to suggest whether or not steroids is advocated in severe leptospirosis. There are 4 studies which demonstrated a benefit of corticosteroids in treating severe disease with pulmonary involvement when it was administered in early course of the illness. However, there was a randomized control trial where corticosteroids were found to be ineffective, and rather they increase the risk of nosocomial infections, which we often see in our ICUs. So, summing up, coming back to our case, now we've discussed the most common acute febrile illnesses where we have hepatorenal dysfunction, ARDS, and significant worsening within few days of illness. Coming back to our patient, we further evaluated him and found that the urine and blood cultures were sterile. Leptospira serology and PCR were negative. Scrub serology was negative. Vidal titers were within normal limits. Influenza as well as SARS-CoV-2 PCR was negative. His viral markers for hepatitis, HIV, and HCV were also negative. We found that his CRP was elevated, his procalcitonin was elevated, his peripheral smear showed us trophozoite of Plasmodium vivax, and malaria rapid antigen was also positive for Plasmodium vivax. To our surprise, he was also positive for dengue serology. Now here we are dealing with a co-infection of malaria and dengue. So with the treatment that we had started him on, his further course in the hospital stay was quite stormy. On day 3 of hospital stay, which is day 9 of his illness, he had worsening of his respiratory distress. He had labored breathing and he had to be mechanically ventilated. He had FiO2 requirement of 100% with the tidal volume of 370, yet his TaO2 was 67, making his TF ratio to be very low, coming into severe ARDS. He was sedated, he was paralyzed, and he was ventilated in prone position multiple times. Patient continued to have persistent fever. Due to severe anemia, he was transfused 1 unit of PRBC. His urine output throughout up till now remained good, and he did not have any bleeding manifestations up till now. So, what are the challenges once we face such a patient who has co-infections? First of all, we must realize that such co-infections are often missed because a clinical suspicion is what is important and a thorough evaluation is what is important. In tropical countries like India, co-infections are very common and they must not be missed. It has been found and seen multiple times that there is increased severity of all the complications once we face such co-infections. There was a cross-sectional study which was done in Brazil where dengue and Plasmodium vivax co-infection of 44 patients was assessed, and they found that there was higher chance of severe disease versus that of a mono infection. There was higher chance of bleeding manifestations, and there was high dyspnea, hepatomegaly, and jaundice versus any of the singular infections. Now, it is important for us to understand that dengue will cause hemoconcentration. It will cause false increase in hemoglobin report, whereas severe anemia is a characteristic feature of malaria. Hence, the management of fluid, the replacement of blood products is very challenging. For dengue ARDS, it is one of the most common pulmonary manifestations in dengue syndrome, followed by pleural effusion. There was a large cohort of hospitalized dengue patients from north of India, evaluated from All India Institute of Medical Sciences, where 3.8% of the patients had ARDS. In dengue hemorrhagic fever, almost 31% patients had ARDS. Corticosteroids have been tried as a rescue medication for severe dengue shock. However, there is not much robust evidence. There is inconclusive data and low quality evidence for the same. Again, fluid management in patients with ARDS with severe dengue shock is a very challenging task. Now, what are the caveats for malaria ARDS? It has been reported in around 5 to 25% of falciparum species. However, even vivax species, as seen in our case, it is seen only in 1 to 10% of the cases. The mortality is very high. It could reach up to 20%. There, the ARDS features have been seen most commonly after the parasitemia level has gone down. That is after 1 to 5 days of treatment, as seen in our case, where the ARDS started to worsen on day 3 to day 5 of illness. So what is the role of steroids? As in any other ARDS, it may improve some organ function score if given early into the illness. It may improve lung injury score and oxygenation. It may reduce the duration of mechanical ventilation and ICU stay. But the chances of nosocomial infections, the chances of a further deterioration still continue. So coming back to our case, on day 5 of ICU stay and illness, the patient continued to have fever spike. His PF ratio improved after 5 sessions of prone ventilation, and gradually we tapered off corticosteroids. On day 8 of illness, the patient had new onset worsening in his FiO2 requirement. He had purulent ET secretions. He had worsening shock. He had AKI. And after sending workup, we found that blood as well as endotracheal culture grew Klebsiella pneumoniae, which was carbapenem resistant. His procal rose from 4 to 14. And we upgraded his antibiotics as per the culture sensitivity pattern. Supportive management was further continued. Finally, after having a very stormy course in the ICU, the patient was tracheostomized on day 14 of illness. He gradually started to improve. His parameters started to improve. And he was finally discharged after 32 days of illness. The final diagnosis at the time of discharge was severe Plasmodium vivax malaria, dengue hemorrhagic fever. He had severe ARDS. He had sepsis, AKI septic shock due to ventilator-associated pneumonia with carbapenem-resistant Klebsiella pneumoniae and bloodstream infection. He also had some form of critical illness neuropathy. However, the patient is following up well in OPD. So what we learned from this case is that continuous thorough evaluation, continuous monitoring, and very careful critical management is essential for such tropical infections. Co-infections are very difficult to treat. They have very poor prognosis. Gracefully, this patient could come out of this illness. However, the mortality rates are very, very high. Thank you so much.
Thank you, Dr. ANIVITA. We'll wait for the questions before just stop the share screen. Dr. ANIVITA, please stop share screen. Okay. So, one question, Dr. Gogia. Sir, are you there?
Yeah, I'm there only. I'm loving your background. I always love that.
I can't see you. So, give the video on. I don't know whether the video is on or not.
Yeah. I'm there, don't worry.
So, about this dengue co-infection, you got an IgM positive, but could that have been false positive? I mean, was there any evidence, pleural effusions and gallbladder edema? Because something has to be there, you know.
So that is always a challenge. But dengue IgM, generally what we see is a very good test. It's a very specific test, which is unlike the IgM for the scrub or for the other tests which we do routinely. The dengue IgM generally is good, and this patient was in that season when there was dengue, and he was admitted with us in September. So that time you are seeing a whole lot of dengue. So any patient who's coming with an acute febrile illness, you are seeing dengue. Malaria per se, we do see quite a lot of malaria, but you would also agree in this part of the region in India, generally in that season, dengue is much more common than malaria per se. But we were lucky that we could pick up the malaria because dengue
even if it is false positive, as Dr. Anvita highlighted, that we need to know. But as you would know, it's more of fluid management and those management, but there is no specific therapy as such. So malaria is important that you pick up malaria or you pick up a scrub, because there is specific therapy per se available for that. So it's important that we look for the illnesses which have more specific therapy. As far as IgM is concerned, generally I feel it is a very, very specific test, and chances of it being a false positive, I generally feel are low, because he had thrombocytopenia, although that can be there in malaria, but leukopenia was there, which is generally more common with dengue than malaria, but obviously it can be either ways. So
yeah, I agree with all that. Although my only comment is that most of the patients, who have severe dengue, if this was, severe dengue, also have gallbladder edema, some degree of pleural effusion ascites, serositis. But it's generally,
yeah,
95, sometimes they may not have, but that is what I have
yeah,
seen.
yeah, I fully agree with you. So this patient did have some amount of free fluid in the chest and the abdomen, although it was not very marked effusion as generally we see in some of the very severe dengue patients. But probably it could be that he had a severe form of malaria and a milder form of dengue. So it's
Yeah,
very
yeah.
difficult actually sometimes to pinpoint when you have a co-infection.
Yeah. So then let's discuss a few things, Dr. Gogia. Maybe you can tell our audience, what about malaria, MP positive and the patient not actually having malaria? The patient is MP positive and he's not actually having malaria. He's just having the malarial gametocytes or whatever. That is also possible sometimes, the patient gets admitted for fever or some illness, you send the malarial parasite, it comes positive. The patient is not actually suffering from malaria. What about those situations?
Well, Dr. Anvita is an expert with us. She will highlight on
Dr.
that.
Anivita?
So, Dr. Tapesh, regarding your previous question, when you mentioned regarding dengue IgM being false positive, so we are dealing with two things. Here we are dealing with one season where we have a lot of dengue endemic in Delhi. So the patient might have had a prior illness of dengue, which can be positive up to almost 3 months. We might be dealing with a asymptomatic dengue infection, which might have had in past, and a co-infection because, as you said, dengue hemorrhagic shock or dengue capillary leak kind of features this patient did not characteristically have. Or as sir said, he might have had mild form of dengue illness with a severe form of malaria. To the other question that you asked, that if we see gametocytes or if we see some trophozoites and the patient is not having characteristic features of malaria, that could be present in hyperendemic areas, such as in Africa, where the patients have certain level of low parasitemia constantly in their blood levels, and they do not mount an illness up till the parasitemia goes to a threshold of more than 50,000 copies per microliter. Till then, they are able to sustain the illness, they are able to maintain it with their natural immune response, and only when the parasitemia increases further from there is when the patients become symptomatic. However, malaria antigen, if comes positive, the parasite level is high enough and warrants treatment. And even with low parasitemia levels, it warrants treatment. Such patients might require prolonged prophylaxis and a long-term therapy, but a treatment must always be done.
So if you get MP positive, then you assume it's malaria. The patient is suffering from malaria in our country.
Definitely. Definitely. And we must treat the patient immediately. We must get a parasite count level estimated to monitor the therapy to look for resistance. And we must further follow up the patient for any sequelae.
Does Odisha classify as hyperendemic?
No, sir. So Orissa classifies as high endemic areas, but hyperendemic areas which have persistent parasitemia in patients is not seen in India, fortunately, up till now. It's mostly in African regions where the vaccine has been suggested.
Okay. So, Dr. Gogia or Dr. Anvita, what is the current treatment of severe malaria? Malaria we get in the ICU as per the latest guidelines. If you can just highlight for the audience. How much?
She's just Dr. Anvita, you just showed the slide. You can just speak about it, Dr. Anvita.
So, Dr. Tapesh, if you could allow screen share,
Yeah,
I
okay.
could go back to my slide.
Okay.
So, coming to the severe form of malaria, we start with artesunate therapy. According to NBDCP, they also recommend quinine as an alternative regime, although because of side effects and because of much safer clinical profile, artesunate is the drug of choice. So artesunate IV therapy of 2.4 mg per kg, that is for an healthy adult of 60 kg, we'll be giving 120 mg. This is given in 3 doses at 0, 12, and 24 hours. Then it is followed by OD regime. So this comes in the formulation by the name of Falsigo. So Falsigo 120 mg injectable, either as IV or IM, and whatever route is preferred can be given. Then once the patient is able to take orally, then we give a artesunate combination therapy in the form of artemether and lumefantrine. This comes as tablets of Lumirax with 80 by 480 combinations. So we'll be giving one tab twice in a day for 3 days, after which we will be monitoring the patient. As per the speciation, we will be giving primaquine for the further completion, and depending on falciparum versus Vivax, we'll be giving primaquine for either 14 days or a single dose.
So there was some recommendation earlier to give doxycycline along with artesunate. That's been removed.
Yes, so there was a recent systematic review which assessed the adjuvant use of antibiotics such as doxycycline and clindamycin in severe cases of malaria that did not find any evidence, that did not have any supportive benefit, because these were useful where we were giving it in cases where which were treated with either quinine or chloroquine. With artesunate combination therapy, resistance is found to be very less and treatment failures are found to be very less. Hence, that combination with an antibiotic is not warranted anymore.
The other thing is artesunate, you said to give for 3 days and then give oral artesunate. But if the patient cannot take orally, then we continue IV artesunate, right?
We will have to, yes, we will have to continue IV artesunate, and then, but however, we have to remember to complete the oral therapy whenever the patient is able to take. Because a single agent, just artesunate, is not efficient enough to able to kill. Artesunate essentially acts on the fast replication of malarial parasites, but the slow replication will not be treated unless we give a combination therapy. Hence, artesunate will be able to treat the hyperparasitemia, the high load of parasites, but not eradicate malaria in the cyclical manner. For that, the combination therapy is definitely needed.
Now, coming to the question of use of antibiotics for gram-negative sepsis. So I believe there has been some stress recently on using early use of antibiotics if the patient not improving or if he's elderly, or some things like those. So what are the recommendations to give antibiotics for gram-negative bacteria? And what is the source of anemia?
So you've asked a golden question. I think I'll need another 3 hours to explain this answer.
So maybe Dr. Gogia,
It's
you
not
can
that
shorten the
simple.
answer. Dr. Gogia, use of antibiotics in severe malaria, empirical use.
Dr. Tapesh, yeah. So that she's answered it rightly, but then there is a practical question which is there. So when your patient is in the ICU, so the current recommendation is ACT, which is rightly highlighted. That is a combination artesunate combination therapy. The problem is that combination therapy, the lumefantrine or mefloquine or these drugs are only available as oral formulations, and they are actually not available as an injectable formulation. So patients who are in the ICU, maybe on a ventilator, NIV, not able to take orally. So it would be a challenge in giving these oral therapies there in those settings. In a patient who is, moderately sick and who improves in the next 48, 72 hours, you can always switch. In those subset of patients, I still feel that a combination with whether it is a doxycycline, although clindamycin is a weak anti-malarial drug, but in those kind of a setting, sometimes you have to use these kind of therapies when the patient is not able to, you do a parasitic index is very high, and the Artemether group of drugs are really very good. But we have seen in a small fraction of patients who have very complicated malaria, severe malaria, especially falciparum variant, especially patients who traveling from Africa and coming back. There, a combination therapy in these form of antibiotics is, sometimes you have to give it. One. Number two, coming to touching on the fact about quinine has been a good drug. We all have been saying the side effects are there. Side effect which we have used quinine. I personally have used quinine, although not to a large extent, but yes. But the major thing which you see is you have to be sure of is hypoglycemia, which is there. But that is not a big issue. You can monitor and take care of. But currently the problem is cardiac manifestations are there, which need to be monitored, but are not commonly seen. But the major issue is you can't get quinine these days. It's not easily available. It's very difficult. I've tried in the last couple of years for two of my patients. I could not actually get quinine because they were not improving with we had a tough time and the load was still high. So that is there. So probably
So what is
that's a
the
little bit of practical.
so what is the indication to give quinine now?
So quinine we have tried in patients who have not uh, responded very well to the artemether group of drugs. So although it is the resistance is low, but it is creeping up, especially in that Thailand Cambodia belt. So there are case reports of resistance there. But so these days patients are traveling all across, so you don't know from where the patient is picking up the bug. It becomes difficult to actually decipher. So in those set of patients who are actually not responding to the therapy, maybe in those settings you can think of quinine. But as I told you, it's very difficult to procure.
Okay. So now just moving on to the investigations, you have leptospira and you have rickettsia. So are you now going for PCR for both of these, or you're still on IgM? Because IgM is not really specific enough, as far as I know, especially for leptospira.
Yeah, so
And she
PCR
had
is
mentioned she had mentioned MAT also. So MAT is not something which is available at all, I think. I do not know what is going on with your GANGA RAM hospital, whether you're doing MAT also now or
no. So that is the major issue. She's rightly highlighted that these kind of tests are there, but they are being done in only research labs or epidemiological labs or labs where, in all commercially available testing, PCR-based testing is actually not practically possible because of the cost effectiveness and things like that. So still majority the test which is being used is the IgM, which is now we were among the first few centers in the private to start doing it, and now probably a whole lot of everybody actually practically is doing it because of the resurgence of scrub. We have seen in the last decade we have seen so much of scrub, so probably it's become commercially viable. Obviously, there is always a caveat attached to the IgM. It is, but generally, I feel in the clinical setting, and especially if you are seeing patients are having an HR, which is actually a diagnostic. You don't even need the thing. So, clinical setting and the IgM actually can clinch. Then, wheel Felix, although if you can show a rising titer, there that also helps, in the clinical setting. So, these are the things which are there. And PCR and all, obviously, it's not practically available all the time.
is PCR available or not available in Delhi for leptospira and rickettsial?
I am not sure. Dr. Anvita would be knowing. AIMS probably must be doing it, but I'm not sure
It's
if it's
available.
commercially. AIMS must be doing it. So labs like those only must be doing it, but it's commercially not freely done.
Dr. Anivita, is it available
It's
commercially?
So
PCR?
it's done in project basis at AIMS, sir. Commercially, GOGIA sir would know better. I don't think commercially it's available
No,
that easily.
it's not
Although
available.
Lal Labs and SRL Labs sometimes do have leptospira PCRs available with them, but whether they are standardized enough to be able to detect with high precision, that is doubt of.
So we are, best of my knowledge,
there are a couple of labs which are doing leptospira PCR, the SRL and all. They are doing it, but again, very limited usage of that.
because IgM leptospira is very non-specific, very non-specific. That
It is very non-specific. So that is why the conventional now treatment of choice in acute febrile illness in tropical countries, the setting is that you give a ceftriaxone and doxy upfront, in these set of patients, because it generally would cover the common tropical infections. So that is the thought process. Still, you are working on these kind of patients.
So we still rely on, there is no real test for leptospira. If you can get PCR done and if you are confident that it's a good PCR, standardized PCR, then only it will help. Otherwise, we really don't have a test for leptospira clinically. And for rickettsia, we have to go with the PCR or we have to go with IgM. But IgM for rickettsia, scrub typhus actually comes positive only after 5 to 7 days of illness. So it comes a little later and again it can be false positive. So that is what I know. So that these, leptospira and rickettsia have to be diagnosed clinically by and large, and an empirical therapy.
Yeah, see, the clinical setting is always there, and PCR test, as a few labs are obviously sometimes doing it, but then sometimes it becomes difficult. Patient is admitted, getting practical issues are there, but yeah, that can be some few labs obviously are running those kind of tests.
So someone has, Dr. Rohit Kumar Garg has commented several commercial labs have multiplex PCR based panels. 2 labs have them as AFI panels. AFI must be acute febrile illness, including so it may be available, but I do not know which lab, and when you send it, you don't really get a proper report. Standardization is also important. They do.
So those are the issues. Yeah.
If you go into it, all PCRs are being done, but what is the validity of the reports also has to be seen. And let's see then. And apart from that, any other questions from the audience? So I think any comments, final comments out of GOGIA, sir?
I think Dr. Anvita has actually covered the whole topic very well, and she's discussed the theory part very well. And so most of the people can go through the video also, and she's covered the tropical infections. And the main thing is that acute febrile illness, you need to keep your eyes and ears open. These are the common ones which are there, and we have to have a strong clinical suspicion. Co-infections do exist, so we have don't close your eyes that if you are getting a dengue, so you can't have a co-infection with scrub, or you can't have a salmonella infection along with that. So you or a malaria. So co-infections do occur. So we have to keep our eyes and ears open, because certain times specific therapy is available, and you can salvage the patients if they get specific therapy.
Okay, sir. So Dr. Anvita, you want to add anything?
As sir rightly mentioned, so the treatable illnesses are very important, that we must keep looking for all the treatable causes of infection. Supportive management is something that is anyways being given. So a very thorough history of travel, of exposure, and of subsequent illness with the family member, epidemiological history of where the patient belongs to, where all the patient has been, as well as a thorough examination on day-to-day basis and the evolution of illness is what gives us some pointers towards each of these tropical infections. Blanket therapy of ceftriaxone and doxycycline does treat most of them. So in resource limited places where we don't have access to all these expensive tests, or we don't have access to sending the samples across to research laboratories, this essentially covers most of the illnesses. However, ARDS and all these terminal complications with MODS are very fatal. They have very high mortality rate. Hence, the patient must be referred to a tertiary care center and to a reference laboratory access. That will be all.
Thank you, Dr. Anvita, for your presentation and your time. So, guys, before we
Thank you, sir.
just a couple of things. First of all, for malaria, send the malaria antigen, send the MP, and if either is positive, you got to treat with the way we have discussed. All right. And if the patient is not improving, the parasitemia is not decreasing, think of resistance also. There is resistance going around now, or there is a secondary infection setting in. Okay. Have a low threshold for antibiotics. That's the new buzzword in malaria. More than before. Earlier also they used to say that 5% of malaria is complicated by gram-negative infections, but now the threshold is even lower in the recent literature. Secondly, for rickettsia and leptospira, especially for leptospira, there is no real test. PCR is available for leptospira and rickettsia in some labs, but how good that PCR is, how accurate that is, I really don't know. So for leptospira, we send IgM all the time, and many a times it comes positive. But even when there is no leptospira clinical feature, you send a panel of tests and you really don't think it's leptospira clinically, still it comes out back positive. So leptospira, no real test. For the rickettsia, IgM is a little better, but again it comes positive only after 5 to 7 days, and it has false positivity. So the diagnosis of leptospira and rickettsia is still more or less clinical. Empirical therapy with doxycycline can help you. So those are the things I just wanted to add. And we have covered malaria, scrub, and leptospira. Dengue we didn't cover because we had an earlier lecture with dengue, complete lecture, and that's on the YouTube channel. So this will be going up on our YouTube channel also. You can go through it. So there are no more questions. With that, I thank Dr. GOGIA, sir, and I thank Dr. ANIVITA. Thank you so much, and thank the audience.
Thank you.
Thank you so
Have a great
much.
Sunday.
Thank you.